to call next meeting to order at 5:31 p.m. Welcome, everyone. Surround the land acknowledgement, please.
The Mischief, the Tlingit, Haida, and Tsimshian people, we respectfully acknowledge them as the original inhabitants of Southeast Alaska. Bartlett Regional Hospital is located on the homelands of the Akwon. We are grateful to provide services in your ancestral homeland and to be a part of this.
Thank you. Do you have a roll call and we have a quorum?
We do have a quorum. Everyone is here, but Chetty.
I would now entertain a motion to approve the agenda.
Chair, to approve the agenda.
Do I have a second?
Second that. Second. Yeah, there.
Do we have anyone from the public who would like to participate? Seeing and hearing none. Now let's move on to the consent agenda. And I would entertain yet another.
It's better ever give the minutes. Move to approve the consent agenda. I'll second that.
Right, old business. Hospital capacity update. Ms. McCallum.
Madam Chair, so for our capacity update, CCU for patient days, CCU had 79, med surg 168, MHU 171, OB 60, nursery 46. The ED saw 1,030 patients last month. Our current census on MHU is 6. We do have 1 COVID patient in-house. And we currently have 3 waiting for subacute rehab, 4 for long-term care. 3 of those are waiting for long-term care Medicaid, and then we have 3 waiting for assisted living. And I'm happy to answer any questions.
Is
the COVID patient they did not come here originally for COVID.
Is the MHU census related to staffing skill?
Correct. I did check with them today. They have 1 traveler that just started. They have another traveler that will start on June 9th. And they have 2 offers out to 2 other travelers. 1 who could start immediately that already has an Alaska license, and the other one they're waiting for a response for acceptance.
And the number of folks that we have waiting for alternate care, is that disproportionately higher or about on par to what we normally see? It seems a little high to me, but
I'll defer to Jeanette since she.
You know, it really ebbs and flows. It is at the higher end right now. And Kim mentioned like 3 of those patients, they're here because we're waiting on the state process for long-term care Medicaid. And yeah, so it is a little bit on the higher end. So we kind of get blocked with being able to.
This number has been higher, but it hasn't been this high in a while.
any other questions? Thank you both for that. Home health and hospice.
So as of the date of this entry on the 20th, home health has 10 admissions with 1 recertification for the month of April. There's 7 admissions pending at the time and 14 patients currently on service. And for hospice, we had 3 admissions for the month of April, but we currently have 7 patients that are currently receiving service. And our average daily census for the last month was 6.4 with an average length of stay for last month as 47 days. It's going up a little. Yeah. Any questions?
Thank you very much. Health report.
Hi, good evening, everyone. So our average daily census for April was over 55. Our skilled versus long-term care is a little bit higher on the skilled side for April, but about what it has been. And our occupancy rate was at 88%. We may see just a little bit of a dip next month because we did drop to 53 residents, but we're currently at 54 today, and we're getting an admission tomorrow and another admission next week. So as far as census, that's all right. Are there any questions?
How's staffing?
We're doing okay. We still have quite a few travelers, mostly on our night shift. And, our director of nursing. And just have positions open out there. So hoping that you want to come to work.
Through the chair, I just want to add to that, there are 16 nursing aides that have started for the team. Hopefully CNAs going through that'll be successful, that we plan to make sure we distribute so those that are short in those areas. So anytime, and like the same plan, anywhere there's a traveler, we find to replace with CNA.
Any other questions? Seeing none? Foundation update, thank you.
Yes, of course, Board of Directors met on the 30th of this month. Quarterly meeting, last month for our quarterly meeting. Now, Kenny, you can say Dr. Bagnarada has been, he almost spilled the beans last time, but he was voted in at the 30th. So he is one of our new Board of Directors. Our health scholarship, the Edelman Scholarship, just closed at the time of this report. We had 18 applicants. It has now been closed, and we are about 23, 24, if I believe is the right number. We're still kind of processing those, and we're going to be meeting with our scholarship committee soon to kind of go through the scoring rubric and review those applications. Enrollment drive is at 34 employees, contributing 580 per pay period. It's up a little bit. We're keeping working on that. The Navy band performed at Wildflower Courts this last. Were you there? I think you were there. It was very loud for me, but I don't think the residents seemed to mind. I was like, wow, for such a small room, it was a lot. But they were wonderful. If we could get them up for Christmas or any other time too, it'd be amazing. They were spectacular. We just completed our Art in the Halls project with the students coming in from Raven Homeschool. They helped kind of reframe, and they took down the old art from our faith community students and put up the new artwork. So we had people kind of fighting over who got to go first, second, third on the choices. And so that was kind of fun to see. All the departments are very excited to pick their art this year. We are working with the End of Life Committee and the Home Health and Hospice on a fall winter speaker series, probably happening in the end of November, beginning of December. And we'll be hosting events for both hospital staff as well as another event for the community, most likely at Centennial Hall. We had the foundation recently approved a part-time position for the foundation. When we move over to our new location here in the hospital, she's already gone through her background check and everything. So just kind of feeling that. And then just listing the foundation investments, we recently added the foundation PICC line training, the safe sitter materials, and then some training for the ED. Any questions for me? Yes.
What you said, you thought that there were 23 applicants
Mhm.
for the element.
Yes.
What is the mix of, I mean,
Everything, really. It's kind of exciting to see. In fact, I saw 2 mental health this time, which in the past, we kind of have a pretty good mix of everything from physical therapy to occupational therapy to speech therapy to nursing. It's quite eclectic. It's quite a good mix. So pretty excited about that.
good here. Any other questions for Melissa?
All very good applicants too. So scholarship committee is going to have some fun on this one.
Okay, thank you.
New business.
Hello, baby.
Hello, everybody. I think you know me. I'm Jeanette Lacy. I'm the Director of Case Management. And this Hello Baby presentation was supposed to be given to you tonight by Rachel Gladhart, who coordinates this program and has really done all the heavy lifting for it. Unfortunately, she had a family emergency, is not able to be here, so I'm going to present it. This is within the case management department in collaboration with the OB department. So I'm going to read her notes so that you guys can really get the information that she wanted to share with you. And I'm really proud of this program and I'm really proud of how hard she works. So I'm sorry that she couldn't be here to share it with you herself. So the way we care for families impacted by substance use and mental health challenges tells a much larger story about who we are as a healthcare system. So today I'll share our Hello Baby A3 improvement framework and talk about how building bridges and not barriers creates trust-driven, trauma-informed, and measurable solutions that support families from birth onward. How this work aligns with Bartlett's vision for high reliability, equity, and exceptional care for all families. So where we provide care matters, as evidenced by our geographic location and the reach of our healthcare services seen here. Hello Baby is Bartlett's perinatal family support program designed to meet the needs of families in Juneau and across Southeast Alaska. We recognize that in our region, where access to care can be limited by geography, weather,
Keep going a little further down.
beginning, and transportation, families need more than a hospital stay. We need connection, continuity, and compassion that extend beyond the walls of our facility. That's okay. You can stay there. I'll tell you when to move on because the slide is a picture of me that you don't need to see. It's part of the stock slide, so just leave it as it is. Bartlett's mission and care values are the foundation of how we deliver patient-centered care, how we build trust within the community, and how we ensure quality outcomes for every person we serve. Hello Baby strives to embody our care values by providing compassionate, non-judgmental support to families to help ensure that every family receives respectful, excellent care from their very first interactions with Bartlett. So let me explain. Okay, where's the Hello Baby slide? There you go. Here we are. Okay. So Hello Baby is Alaska's pilot plan of safe care program funded through a contract with the Office of Children's Services. Plans of safe care are federally required, family-centered safety plans that connects families to medical, behavioral health, and community services. The goal is to reduce child welfare involvement by offering upstream supportive care for families experiencing perinatal substance use, mental health concerns, or social stressors. At Bartlett, we've created a universal tiered model supporting all families to reduce stigma and promote equity. Since launch, we've increased perinatal substance use screening from 40% to 94%, launched 3 new parenting programs focused on recovery, mental health, and nutrition, created a digital support initiative to maintain family engagement through baby's first year, helped shape Alaska's statewide plans of safe care strategy, and helped shape Alaska's updated pediatric newborn toxicology protocol, which now encourages other birthing facilities to adopt similar approaches. I don't think that Rachel highlighted this piece enough. Bartlett is the model that other facilities across the state are coming to us to figure out how to move this forward in there. Like Anchorage, everywhere, like Bartlett is the model. So I really feel proud of that. And all the work that she's done with this going. So we shifted Bartlett's culture from mandatory reporting to mandatory supporting. And this is something else I'm really proud of. We are actually going to be creating a training for all Bartlett staff based on this model of supporting families through that mandatory reporting process instead of, all healthcare providers are trained. You're a mandatory reporter. You have to report. Okay, well then what, right? Like, how do I do that? What does that mean? So we really want to support families. We're mandated reporters, but we also want to support them through that and not leave them wondering what to do next. Currently, 1 in 4 Bartlett births involves a risk factor requiring additional support from substance use to mental health or lack of resources. So in short, Hello Baby ensures strong supported starts for every Bartlett family. So this is intended to sort of give a example, and I don't have the example of the family that Rachel shared when she presented this with A3s, but this is sort of looks a linear, process of how a patient would get involved. And so we do really warm linkages with the services that the patients need. And I know that Rachel receives lots of communication back from moms who have been reunited with their babies or their other children. They've had their babies, they've been through treatment, they've maintained sobriety for a year, gotten other children back, and these parents, stay in touch with her. And it's really amazing and really, I think those stories are fabulous. So I'm sorry I don't have the exact story she shared last time. Okay. Thank you. We were honored to have Hello Baby recently featured in a blog post by the Alaska Children's Trust, a statewide organization committed to child and family well-being, awarded Hello Baby a grant in 2022 for a harm reduction and contingency management program. The post highlights how Bartlett Regional Hospital is working to support families in relationship-based care. And she thinks that this quote from their post effectively captures how our program directly supports it. So the positive go ahead. That's fine. Hello Baby aligns directly with Strategy 1 of Bartlett's strategic plan. And that we go through that here. So, sorry guys. Okay, go on to the next slide. You must have purple. Hey, nope, here we are. We're on the same page. Okay. Hello Baby supports Bartlett's 2025 strategic goal of selective investment and growth by building a scalable integrated model of perinatal care, extending technology, integrated tools, replica models, enhancing continuity access systems, inpatient to outpatient bridges, achieving top quartile quality, reducing complications and crises by identifying risk early, high reliability organization readiness by delivering standardized trauma-informed care that builds across disciplinary safety culture, and improving patient satisfaction by providing compassion, not judgment, to build trust and higher satisfaction. So Hello Baby is more than a program, it's a strategic investment in quality, safety, and trust for Bartlett's most vulnerable families. Okay, here we go. Go on to the next one. Here we go. So we have this A3. Our stated problem is that an opioid crisis impacts Alaskan families disproportionately compared to national trends. Hospitals face growing challenges in achieving cost-effective care for patients with substance use disorders while complying with federal requirements and improving infant safety and family. In scope is all perinatal patients and relevant clinical teams throughout Bartlett, and how is non-perinatal patients. Go ahead. So looking at the background into which Hello Baby was created. So recognizing concerning child welfare outcomes and gaps in services for new parents with substance use issues, Hello Baby started with case management services in 2021 and in partnership with OB, and expanded into comprehensive relationship-centered model of care, now on its second state 3-year contract. Hello Baby offers universal new parent support with evidence-based treatment level parenting classes for families with substance use issues, perinatal anxiety, and a mood curriculum, a harm reduction approach with safety items for babies, and a contingency management program with concrete supports. To better understand why this is a national epidemic and a deep persisting problem in our community, we looked at both internal processes and external barriers that families face for root cause analysis. Systemic barriers to accessing care, limited access to coordinated perinatal and substance use treatment services, especially in rural or underserved areas like Juneau, punitive and stigmatizing systems, criminalization and fear of child removal discourage families from seeking care or disclosing substance use. Gaps in early identification and intervention, lack of universal screening and response protocols for perinatal substance use and mental health. Missed opportunities for early engagement, inconsistent implementation of safety planning across hospitals and communities, underinvestment in preventative and supportive services, and intergenerational trauma and unaddressed mental health needs, high rates of adverse childhood experiences among birthing people affected by substance use, intergenerational cycles of trauma, substance use, and child welfare. So the goals: ensure Bartlett's validated universal substance use screening for all pregnant patients at their birth encounter achieves a 95% screening rate, complete, partial, or attempted by September 30th, 2025. Improve completeness of substance use screenings from 40% to greater than 75% by September 30, 2025. Provide brief intervention and motivational interviewing training to 100% of obstetric nursing and case management team at Bartlett, aiming to deliver brief interventions to at least 75% of pregnant patients who screen positive for substance use. And these goals are based on WHO guidelines for the identification and management of substance use and substance use disorders in pregnancy. We have identified 5 countermeasures. Standardize early identification and referral pathways. So refining our EHR screening obstacles in OB admission assessment, and provide staff training on evidence-based SBIRT, which is screening, brief intervention, referral to treatment, trauma-informed screening, and referral conversations for perinatal substance use disorder and maternal mental health positive screens. Normalize and humanize Hello Baby and plans of safe care as part of routine postpartum discharge planning. Enhance community-based supports and engagement. Partner with city and tribal entities to offer low barrier wellness access. Promote harm reduction and safety culture. Expand harm reduction tools. Provide staff training on stigma reduction, perinatal substance use disorder best practices, and measure impact. Track and report on KPIs, substance screening rates, complete documentation and report rates. Our KPIs: 95% of birthing parents receive an EHR documented substance use screening during their delivery stay and tracking that quarterly. 100% of positive screens are referred to Hello Baby, and 100% of OB nursing and case management staff are trained in evidence-based engagement strategy. Follow-up actions, audit and feedback loop, chart audits monthly for substance use screening to ensure fidelity to workflow, identify missed opportunities, provide real-time feedback to staff. Staff training and protocol refresh, conduct annual training sessions on universal screening, trauma-informed care, referral pathways for new and existing staff. So in conclusion, Hello Baby has filled some critical gaps in perinatal care by supporting families impacted by substance use, mental health challenges, and high social stress. This program is aligned with Bartlett's 2025 strategic goals to advance health equity, reduce preventable harm, and strengthen continuity of care. Through our A3 process, we have identified targeted improvements, implemented new evidence-based services, and began tracking measurable results. Data shows real progress, especially in engaging high-risk families more effectively, screening OB patients for substance use, and building better services for our families. Hello Baby is committed to being a scalable, cost-effective, and mission-driven investment in the health of Bartlett's families. Questions? Thanks.
Thank you, Jeanette.
Yes, fine.
So I got just a couple questions. Can you screen without permission? Or does the mother have to give you permission to do screening, toxicology screening?
Well, it's, the SENI screening is asking them questions, and so it's part of their admission process, so. Oh, yeah, like, it's not a lab test, like, yeah. The SENI screening is they do an assessment with the patient, not a lab.
And then the baby they would have lab testing if you guys
If
thought.
there was concern, they could do like a meconium screening. That's how they would know if it was something.
Would I have to get permission from the family, or can you just do it right from the? Something like that?
I can't answer that question very directly. Yeah, I don't know if they.
I mean, I can kind of speak to that since I deal with that, I guess. So I think it depends on your level of concern, right? So I think, I think there always the intention is to get permission from the mother. And I guess I would just kind of highlight, I think what a benefit having a program like this has been at the hospital, because I think many times it's, left to physicians, which sometimes we have a good relationship and rapport with patients, but I think having other staff members be aware and being able to help contribute to that conversation, I think really helps to destigmatize it. And I would say the majority of the time, I think most parents, when it's put in context and realize that really the goal is trying to promote health for their baby, I think there's less stigma around it. And I think programs like this have really helped all levels of staff, I think providers included, to be able to help destigmatize it. And so I think it's often less of an issue, but I think, as it being a mandatory reporting thing, if there's concern for the well-being for the child, that can cement precedence over consent.
So one of the things that mandatory reporting, instead of reporting mandatory
Supporting.
yeah.
And it's still mandatory reporting, right? Like we are all mandated reporters, but what that means is talking with the parent, explaining to them that that we are mandated reporters, but that we're going to support them through this process and we want to help give them the resources that they need. So letting them know that we need to do this, but that we're going to walk through it with them versus, maybe just calling and them not even knowing that OCS was called and the report made. So we're letting them know that upfront. And a lot of the times the parents do want to be part of that conversation. So I think that's really valuable because it's engaging the parent from the very beginning of that process and getting them linked with supports and making them, building that trust with them so that they're willing to engage with the services and supports that we can offer.
Well, I had two questions, and one was about the mandatory reporting. So I too was curious as what it was that was a positive result. And so now I understand that's just interview, but then you must report that to the Office of Child Services.
Yeah, I mean, if there's a baby born with, prenatal exposures, you do need to report that, but we talk through that with the mother.
But I was kind of curious, what is the consequence of that?
It really depends. I mean, it depends on that person's history. It depends on, okay, they're working with Hello Baby, they're making a plan of safe care, they're doing this, and this. Okay, it's just on their radar. It doesn't mean that they're gonna, get involved but it's on their radar. And so I think that's the other really positive part of having Hello Baby go through that process with them, because we can create a plan of safe care right there and share that with OCS, and OCS knows, okay, they're engaging in this process, versus if you have a parent who says, I don't want to be part of that, I don't want your plan, I don't want to do this, well, then it's going to have a different outcome. And OCS might do a deeper investigation, they need to be involved in that process, and it could, depending on the history, could, involve removing the child from that environment.
The other question I had is, there was the compound adjective was used a couple of times, trauma-informed something rather. I couldn't really figure out what the intent was from the context. What's the intent of that?
Right, so, trauma-informed care is understanding how to work with folks that have a history of trauma without re-traumatizing. So how you're doing your interviews with them, how you're engaging them in services, we really don't. So you don't want to ask a person with a long trauma history, have 3 different people ask them to go through that story. As people come into the hospital, right, they might get the same questions from different providers. We don't want to ask a patient with trauma to tell us about that trauma 3 times. And then also understanding, are there certain triggers for that patient, and how we communicate that with the rest of the care team, because we want to make sure that that patient feels safe and that they, we want to reduce any kind of re-traumatization as much as possible.
Thank you.
Dr. Rester?
I have just a comment and a question. That's this great program, and have you advertised it? And if not, then maybe put it in the flyer.
I know that Rachel works with all the clinics in the community and promotes this. We really try hard to get engaged with families early in pregnancy, especially if they have any substance use or mental health or anything that they might need support with. So she's done a lot of work with all the clinics that are involved with pregnant patients. We do work with AEYC and other agencies. So, and then we offer the services to everybody who comes into the hospital, and we'll do postpartum callbacks to check in.
And then my question is, I heard you say something about funding a grant or something.
It's a state contract. So it's a federally mandated program. And so the state put out an RFP, and Bartlett applied for it, and we received the contract now 2 times, 3 contract 2 times. And then our ACS grant, Alaska Children's Trust, ACT, thanks. Kind of like, wait, that didn't work. Our Alaska Children's Trust grant that we've had also has provided a lot of funding. We are able to provide, lots of different items, diapers, car seats, food, lots of different things. We try to help engage families. And so when they're engaged in that program, that helps with that process too.
And just a follow-up question if I could. And this may be for Joe as well as for you. Is it, given the state's, limited resources and then what's going on nationally with all the cutbacks, could it be that any of these funding sources could be somehow restricted in the future?
Right, like that is a question, right? We'll have to see what happens, but as of right now, federally mandated in the state, we're just 1 year into our second 3-year cycle, so we'll have to see what happens. But I don't know what's going to happen with that contract.
Any other questions?
Can I add to that answer?
Sure.
I do feel very hopeful though, because the state of Alaska, we work with them very closely, and they have been asking us to be that resource for other hospitals across the state. So I do feel positive about that, I guess, for right now. Who knows, right?
I was just gonna add a comment, having worked with all of the folks through Hello Baby, both before babies are born and then afterwards, and helping folks transition from in the hospital to the outpatient setting. I think this program does a fabulous job in helping to facilitate that and helping to facilitate. I think when patients are in the hospital, it's in a contained unit, and it's a lot easier to implement some of these, but it's programs like this that really help to facilitate families that are having a harder time for a whole host of different reasons, and helping to facilitate them making their follow-up appointments and helping. Sometimes it's as simple as like access to car seats and access to ideas for transportation. Like, how do they get to their follow-up clinic appointments? How do they engage with the healthcare system? And Rachel has done a really fabulous job of being available and helping those families when they need that help. So I think they've done a lot of work in the hospital and trying to help with this, but their care really extends beyond that. And I think it makes a huge difference for families. So thank you.
Oh, thank you. I was just going to add on to that. Thank you. I was a bedside social worker and before this program, and it is challenging when the patient's here for that birthing period to engage them, especially if they have, you know, any concerns or fears or things like that, being able to start the work immediately and then have, it's for a year postpartum. So sometimes, you know, patients are not, they don't want to engage when they're here, but we do those postpartum follow-up calls and maybe a month, 2 months, 3 months down the road, they're ready to engage or ask for help. So I think it's really great that we have a program that's not only looking at this little window of time.
Go ahead.
The chair, I just have a comment too. I actually had a really in-depth conversation with Rachel too, so thank you for sharing. And I had questions that are very similar, but one of the things that I thought was very interesting was, you know, a lot of it is, you know, case management with the harm reduction and the mental substance use. But one of the things that she also reached out to me about was that 30% of those that are coming to them are often just non-supported. Like they don't have any support in the community. They might be homeless or those kinds of things. But then the other thing that I thought was interesting about the grant, I guess it is about $39,000 a year, and it could be gone. We don't know yet. But they do pay for car seats, pack and plates, supplies, postage. But the other thing was bus passes, transportation, and then CBG activities. Like it could be like a pool pass or something for the kids to do, a field house or something like that. So it's kind of encompasses quite a bit. So it's an important grant.
Yeah, the Alaska Children's Trust.
And are we, at this point, the only recipient of that grant in the state?
I don't know what else the Alaska Children's Trust funds, but we are the only recipients of the state contract with the state of Alaska.
And as part of that contract, you mentioned that they're reaching out to you to assist other hospitals. Is that part of the contract, or is that just an added benefit for the state and for?
Well, we have obligations to continue to work with the state and partner with the state. So that is part of the contract. I don't know that that means that we like help set up a new program, but we do serve as a resource.
So for other programs, they would not have the benefit at this point of any supportive funding from the state as we have. Is that correct?
That's my understanding. That we're the only one with the contract, so.
Then I guess one last question from me is you have talked about both prenatal and postnatal, you know, a year after delivery, and what that year after delivery looks like. What does the prenatal engagement look like from the Hello Baby perspective?
Right.
I don't know if maybe between the two of you, you could.
So, you know, a provider in a clinic could reach out to us and say, hey, I've got this patient. She's really struggling with this, that, and the other. She's interested in getting help with Hello Baby. Can you know, and then we would start working with them right away. Other times we have a patient maybe who's coming into the ER, and we will, the case manager of the ER will make a referral to Hello Baby, and we'll reach back out to them and try to engage from that point. I've had providers use our EDDI system with the ED program and say, hey, we've got this pregnant patient. They're not coming in for their OB labs. When they coming back in, can you get those labs? And then we also then can link them up with Hello Baby. So we've had them linked from the mental health unit before. But yeah, you know, so wherever we can find these patients that are struggling or get those referrals in, we'll reach out and try to start building connection with them before they come in to deliver.
Any other questions or comments? Thanks, great work for that team. And you.
Oh, thank you, Rachel. With Rachel, please, she's fabulous. So, thank you all.
Thank you for us too.
I will. Thanks.
Mark's financial, so due to the ability to have a quorum, the finance committee this meeting, both financials board for a brief presentation here for the full part. In March was our first month in the red. We did have some of the drivers from that weather. We had some services that we started the prior year, home health and hospice, as well as anesthesia. When we're getting a roll with the program and going through the survey process, any claims or any services provided for the survey when we actually got the licensure were disallowed, and so Medicare wouldn't pay for them. So we had to write those all off. We had gone through a full appeal process, so that's why it took so long to get here. So we were fighting the board trying to pay.
And what was that amount to?
I believe it was 290,000 for the home health and hospice combined. And then there was another chunk for anesthesia. I want to say it was a little over 100,000. So like 390 total written off.
That's that negative contractual allowance we booked in hospice and home care for the month of
Yeah,
March.
that's that big bump right there. That's why you see contractuals as a percent of total revenue jump up quite a bit during the month as well.
Yeah.
Typically you are. So if we would have had a perfectly clean survey, you would have gone back to that first day of service. I've gone through surveys with new services in the past. I've never had this issue before. So that's why we went through the full appeal process and filed it all the way through. It is a different contractor. So we're used to dealing with Noridian for most of our hospital and clinic services. This was NGS. So I don't know if that's the driver behind some of these write-offs.
What was their reason for it?
Technically, your enrollment date in the survey is when you, in the services, when you get a full clean survey. Since we had some deficiencies when the survey came through, it wasn't until we corrected those deficiencies that we were actually fully enrolled in the program.
So they did this on 100% of the revenue while those deficiencies were.
But everything prior to it, yeah.
How many days was that?
6 months, it was a chunk of time. We had other carriers that paid up to that point, just not Medicare for those services.
I have a question. If the anesthesiologists, like in the old days, were their own solo providers and not contracted, then we wouldn't have lost that money.
Well, that was home health and hospice. Anesthesia was slightly different. It had to do with so we applied for 10 and a Medicare number. So anesthesia was different in that we had to spin that program up from ground up so fast. We just didn't have time to get all those things in place. So it wasn't a deficiency. That was just, I think we signed the contract mid-November and we went live December 1st. There just wasn't enough time to get all that stuff in place.
I remember that.
Yeah, and I think they signed the contract my first day as CFO, and so it was too much to get done in too long time. If we would have had 45, 90 days, it would be easy.
That didn't impact hospice. That was just home health, correct?
That's my understanding. The enrollment piece. I believe hospice had a good clean enrollment, so those seem to pay fine. Contract expenses, we still have issues with contract labor. Expenses were higher this month as we had to change out some of our invoices that need to be cleaned up. So we were still under budget for overall expenses, but we did have that net operating loss of 330,000. That was offset by interest income during the month. And so some of that interest income, we expect some negative months to come in the next few months as some of those dips in the market are realized. Overall, a net loss of 110,000. Year to date, we scale positive with a 4.2% operating margin and a net margin of 5.4%.
I don't want to beat this. I'm sorry. I don't want to beat this, but if we did not have an issue with that survey, then we would have. We would have been in the black this month, not.
Yeah, because that was just. The only reason we were negative this month was from those past service issues that we had during this month. Maybe we could have gone through a accounting process and allowed to get onto Jim, but then that doesn't help us anyway. And once you know about it, you're supposed to realize it. So that's why we did it this way.
Well, and to your point, I mean, when you get back to the follow up on what Kenny said, on the hospice and home care basis, it's almost half the loss.
Yeah, and then what does it apply to this year? You know how stuff's supposed to be recorded next.
Yeah. Yeah.
I guess the biggest thing is sorry. I guess the biggest thing is I just kind of don't want this to
alarms to the workforce. So I don't know, to achieve the 9% this little blip here is mostly because of something that happened. Yeah. Almost beyond.
To be honest, I'm thrilled it took us this long to get to the negative. As we went to the winter months, we usually see revenue drop off so much. I expected this to happen back in November. So just to happen in March, I think is a win for us. But as we look at revenue that happened in April and as we start stabilizing, expenses, I expect April to be back in the positive.
Any other questions about this specifically?
No, I just want to just add that, we should be very proud of the fact that we have, this current month, this $110,000 loss has buried in it $200 and some thousand of a contractual allowance that related to FY24, not FY25, number one. And number two, that's the only loss that we've had in a month this fiscal year, which is also remarkable. I mean, in any of the best years in Bartlett's history, normally January, February, March, you were spinning at wheels and had small losses.
So I wasn't going to go too much deeper. I was just going to touch on income statement. I was going to go to balance sheet or volumes, unless people had questions, and I can cover those.
Because we didn't get a chance to talk about this at the finance committee meeting last week, at the February finance committee meeting, the March finance committee meeting, we looked at an initial draft of the update to the 5-year plan for hospice and home care. And there were some changes and some further work that you were going to be doing on that and bring that to us so that we could act on that and share that with the people that are interested in it, Juneau Community Foundation being the most important. And so what's the status on that, Joe?
Me and Chuck had sat down and made some changes to it. We'll update it with the year-to-date numbers when we close out April, and I'll bring it to finance committee next month.
Okay. That's great. Can you share that with the committee ahead of time, just so we have a chance to chew on it?
I'm probably going to bounce off you ahead of time because I know you're going to ask the most questions.
Thank you.
Any other questions about this? Do you have anything else about the finance report?
Yeah,
That you want to share?
Yeah.
All right. Sobering center discussion.
Okay. So at
That's where we're
that,
at.
yeah, we're at the
Yeah.
the change gears here. So at the May 7th Assembly Finance Committee meeting, there was a suggestion from staff to the Assembly to utilize our RRC space for the sobering center and move it out of the St. Vincent de Paul space. Several of us attended that meeting. We came and we tried to answer some questions. I prepared some information prior to that meeting. So as we look at the RRC space, we had plans internally to how we use that for additional clinical services that are needed in the community. Namely, we've talked to Alaska Heart and they for cardiology services. We have dermatology we've had discussions with. So we're trying to, try to make that a clinic space to, increase revenues and add big services to that are needed. And so we presented that to the Assembly, and through their motion, they directed us to work with staff from the city side to come up with some long-term solutions while using part of the RC for a short-term housing for that program. So we've had conversations with the city. I think there was some misinterpretation of what the direction for the Assembly meant. So we had conversations with KB Kester and Robert Barr last week. There was some communication that went out through CCFNR that Bartlett was going to pay for all the services and all the remodel, which was not the intent or now how the motion was worded. So we have a kickoff conversation this Friday with Robert Barr. Me and Kim will go down and we'll start those conversations on how we help them come up with a long-term solution for the sobering center while trying to, how do house it in the short term and get to a long-term solution faster so we can utilize the space in a way that's productive for Bartlett and the community. I guess with that, I'd open up to questions. I think I tried to send a lot of this information out prior to the finance committee, so hopefully you guys got the time to read those packets.
You provided a memo like that, Joe, back to the assembly as well, when you saw Robert Barr's memo. And Robert Barr indicated that the cost to remodel was going to be 600,000 or somewhere in that ballpark, I think. And what was the 1 year the revenue loss of the hospital that we would have if we weren't able to do the things that you're planning on doing in that space, just the first year?
Just the first year when it exceeded the cost of the program or the renovation. And I think it was 550,000, and it was based on some estimates. So there's some pretty good data on there on what the revenue impacts are from bringing a cardiologist to town, what an FTE is. So we figured what 1/4 of that would be, or it was 1 week a month is what I was trying to figure too. So we've used conservative estimates what the impact of cardiologists would be. The impact of the hospital is, imaging services, lab services, stuff like that. And then dermatology, there's also some additional ancillary services from them. It wasn't quite as much as cardiology because most of that is just outpatient. There's a little bit of lab, a little bit of pathology we could see, but it's minimal dermatology.
Yeah. So the short-term sobering center that they're talking about putting in there, what is short-term?
That's yet to be defined. Hopefully, my short term would be 90. I don't know what they're.
I don't think I have a firm answer. I did talk to Katie about it today, about Kate Kester. She is still looking for long-term options. So definitely, as Joe said, very much short-term. I don't know what short-term means in terms of actual timeline. So I don't know how long the renovation, if we chose to renovate the existing space, how long that would take. I don't know that time.
Yeah.
Anything, please.
So I guess I've got a couple of questions. One is just first, I guess, from Dr. Reister's 30,000 feet, we are a community hospital. The percentage of the people that we would serve in the sobering setting versus the percentage of the people that we would serve in cardiac and dermatology in that, do we have an estimate on what that would be? Like if we're going to serve 0.5% of the community in the sobering center and with, and I know the numbers, and with cardiology or with dermatology, we're going to service maybe 4% of the community. I just want to make sure that all involved know these numbers, that we're really trying to affect the most amount of people in the community. So I think that's really important for the assembly to be aware. And with that being said, having a sobering center on this campus opens the city up to such huge liability. I'm not really sure that they understand what the liability is. So if someone is in the sobering center and dies, the city automatically becomes responsible for that death because of the detoxing. Detoxing from alcohol is extremely dangerous. So just having that liability on this campus is really kind of scary for us.
I do want to comment on that one. The city is liable where they're at as well. It doesn't matter because it's a St. Vincent de Paul does not operate it. CCFR operates it, and it's a leased space. So they bear the liability. That's not particularly an issue of where the location is. Wherever they choose to locate it, it's going to be a potential liability for the city.
Isn't it no liability to be on campus lots?
I can't answer that question, but regardless, if someone dies wherever they're operating it, that is a potential liability. Lisa.
Oh, couple things. I realize it's potential liability for the city, but the emergency room is right across the parking lot. The other thing is, and maybe I'm being cynical, it sounds like Rainforest Recovery Part 2. I mean, that we're just gonna restart it, only with a different name, and I'm questioning if that will also be how it's perceived.
There's concerns from staff side as well. If Rainforest Recovery was intended to help those that were wanting to get well from the disease. And so they were trying to recover. We don't see the sobering center as that same population. These are people that continually use sobering center to get sober so they can get sober the next day. And so we were treating people before. This is just housing. Now, believe it's the city's goal to have us house it long term. It's just to transition it from a space that's unfit for people to reside in at this point.
I mean, and so the campus that's being built in Lemon Creek that we looked at, where they've built some beds, I understand they've had some little bit of funding issue, but has that area been looked at?
So we've discussed that well. GHS is a potential option. So I know in the memo Robert Bark created, there was a couple options. We brought a few more to the table. And so our hopes as we start having these conversations, these meetings with the city, we can bring this forward. So GHS is a possibility. Another one we brought forward is we have a mobile building that we had for COVID that's just sitting unused at the bottom of the hill. Could we have the city use that as a space? If they have somewhere to set it up off campus, preferably. But some of those discussions. So our plan is to meet with the city, try to come up with some short and long-term plans, and then bring it back to planning for consideration for the board. Just the way the two entities work, I'm not sure how this is supposed to work. If I'm supposed to go through this board for approval or the city for approval, it's just one of those weird in between things, I think.
Yeah,
to be clear, I think you've already answered this, but they're just looking for a space. We're not going to staff this.
Yeah, we're not going to operate. This isn't going to be a Bartlett space. It's basically a space for them to use, and it's still going to be staffed by the same people. It's going to be run by CSAPR. So the problem before, it was a giant cost sink for us. So as we operate, if they start pulling all our overhead into the service and it costs us, we'd be the most expensive operators of this program.
But we also have the opportunity cost of not being able to house medical services in that space, which was what the board's plan was for them.
And we shared that with the assembly as well. Correct me if I'm wrong. I think that the assembly understands that it's not from my conversations with assembly members prior to the finance committee. I think everybody understands that Bartlett is probably not the long-term solution, but depending on what the long-term solution is, there's a strong potential that for some period of time, depending on what the solution is, our space might have to temporarily house that service.
Temporary has a way of
Also
becoming permanent debt.
as we start having these conversations with Alaska Heart and Vein, I mean, the space bar RC isn't ready today. And so if they are using it temporary for the sobering center, that would also open us up to renovating the extra space that we. It isn't the same space. So they want space that's kind of round the backside of the corner, and I want those first 4 to 5 rooms to be the clinic.
So it's not the core area, it's the original, that was your original concern.
Yeah, so what we could use it for that while we renovate this next phase too. So we can try to run the two projects side by side, hopefully. And hopefully they can be moving out as we're opening the clinic, so we're not having to cardiology clinic run next to the cellular center.
It would be wonderful to have space for Alaska Heart. As an Alaska Heart patient who has to go to Anchorage to deal with my stuff coming up pretty soon, and I'm not the only one. I mean, it's very expensive to do all this stuff with Alaska Heart, and so I mean, I think it'd be wonderful if we could do that. I saw that space a couple weeks ago. I was amazed by it. It's absolutely beautiful, and the thing is we have an aging population, and to Kenny's point, I mean, I absolutely hadn't even thought of it until he said it. It's just, there's a whole bunch of people that need that service or will need it. And I'm not downgrading sobering center, but I just think that, before we,
So if the board's okay with it, we'll start conversations with the city and bring that staff planning committee on the 12th of June. Is the next steps. That was my initial plans, if that's working.
From my perspective, yes, I don't know if there's any negative feedback on that board.
I would caution us to tread lightly. Because I think that the board has already kind of shown what we wanted that building to be and what services that we want for our community. So being someone that's been on the homeless coalition and been worried about, people that substance use disorder, again, sure if that's the right thing for our hospital to be involved with right now. And it's going to affect a very, very small percentage of our community. To use other things to affect a larger percentage of our community that we want to think.
If I may, but we do serve at the pleasure of the city, right? So just to put the order of priority, we can make all the requests we want, but these are the elected officials that are responsible for making decisions.
That's what they want us to do. We're 100%.
I am too. I'm just reminding everybody what we went through in the last year over these conversations. And it's like we're circling back and we're heading right back to that cave. So that's all I'm saying.
I think it's top of mind for all of the board members who have painfully gone through the last 18 months or plus. Any other comments about the sobering center, the process going forward? Okay.
So from the head staff report, and I apologize for maybe not communicating this. I guess we did have a vote during our last MedStaff meeting on a few very small bylaws changes. There were the two committees, the Behavioral Health Committee and the Emergency Care Committee, had asked to change the required frequency for their meetings. I guess technically everything should go to the board for approval through our bylaws. It's not a substantive change. They wanted to reduce it to quarterly, the minimum requirement for the meetings, as opposed to, I think it was 6 for ECC and 5 for behavioral health. So the med staff did vote to approve those changes, but I guess technically it would come to the board for a vote if the bylaws change. But sorry, I didn't get added as an action item there. So.
I think we had a conversation earlier that non-substantive changes like this were information, could be information only. Unless anyone here has a big problem with that, I think we can continue to move forward with that.
So, yeah, that was the only, that was really the only major thing. And then obviously the rest of the stuff later on. Any questions on? It's right in there.
Okay. The updates. Quality and compliance. Kelly is not here. It was a long meeting. And I don't know, Gail, as our staff, would you mind hitting the high points for us?
I
do think that the minutes reflected the discussions during the meeting.
Yes, I think they did. Yes, I think they reflected all of it.
The highlights were Wildflower Court, did have their survey, and they did, had a pretty good survey. There are a few things that they are fixing. The survey results came the day after the meeting, so Deb is working on that, and we have 7 days left that she will be putting in her changes on it. And we did a education session on the OIG regulations on long-term care and subacute this month. So there was a information in your packets that all board members got on the regulations that they came out with in November 2024. So if you weren't at the meeting, feel free to read those over because they hadn't been updated since 2008. So.
Any questions? Thank you, Gil. Hey.
So I have my CEO letter in the packet. I hope everyone had a chance to read it. The big issues that we have that we're looking at is continue to be federal budget changes. The budget did pass out of the House and is at the Senate level now, with multiple changes to Medicaid. So we'll continue to watch that to see if there's more changes to Medicaid, more cuts. I tried to put the ones that we saw as substantive to us in the packets. The other piece that I wanted to make sure that everyone is aware is the Rural Community Hospital Demonstration Program that we have been a part of since 2008, I believe. And it's funded.
It's longer than that.
Maybe I'm saying it off by here. It's funded, technically the program is funded through 2028. Our 5-year demonstration program ends on 6/30 of this year. So I've been working close with both Senator Murkowski and Sullivan's office to try to get us back in. So what they've done in the past, to some variation, is basically put us in. So we're part of that last couple of years of funding, and hopefully it gets extended beyond this. We've been in this predicament before, and it's been extended in the past. They have every confidence this one would be extended because the number of hospitals and what they call budget dust is the value of it compared to the federal level. So we'll continue to work with them on getting this push forward. But I just wanted to bring it to everyone's attention. I think the worst case scenario is maybe we don't have something in place and we start doing July and August financials, but we'll have something before the end of the calendar year, hopefully to have in place.
Joe, just for the minutes, what is the dollar impact to the hospital per year of that program?
Somewhere between $4 and $4.2 million a year.
And Joe, that's gone up over the years, right? Because it was like, it used to be like 3.4 and now it's up to 4.4, right?
Yeah, it's gone up. It varies from year to year and how much we have from inpatient. So it's, so like as we look at the current year, we've had increased census, which would be a cost shift to the inpatient unit. So I expect FY25 to be more than FY24.
Director.
And I've heard this death knell before, that this rural demonstrations finally ended. And so the hope is that it will continue. But there's this sort of overhang of the federal, what's going on, in the House and the Senate. So you're hoping that this will be promulgated without, because it doesn't need an act of Congress. It can be done within their budget already.
Yeah.
Okay, because a new act from Congress, hoping on that, I would suspect would not happen.
Probably. Yeah.
Okay, so it's within existing funds, they think.
Yeah.
Okay, thank you.
It's technically the program is fully funded through the end of 2028. Another thing we continue to watch is tariffs, and it's kind of in the news, out of the news, up and down. But so I just want to make sure everyone's aware. With our GPO, most of our everyday medical supplies are protected from increases from tariffs. And so we have locked in pricing for most of the stuff. So either 3 or 5 year contracts, and they're constantly renewing these, but we haven't seen any substantive impacts from our everyday medical supplies and physical.
It would be a longer term shift.
It could be a longer term shift. Ideally, some of these things play out over the course of, this administration, the next one. So we'll have to watch and see how this stuff plays out.
So Joe, just to understand, oh, go ahead, John.
Okay, sorry I'm going to shift subjects a little bit. So if you want to go ahead.
Yeah, I do have a GPO question. So why wouldn't it have impacted our prices on GPO? They can reset for things like this, can't they?
So the contract they have with the supplier, there's a non-termination clause and there's no way for that person to get out of it. So what they could do is try to limit the supply at the cost we get it at, which could start going down to rationing of those supplies. That's what the GPO could see as the worst impact for us. Because there's, guaranteed quantity, and the guaranteed price of the contract. Does that make sense?
It does, yeah.
And our GPO is one of the largest in the nation. So when they negotiate a contract, there's no way out of those contracts for those companies.
Interesting. Thank you.
Dr. Russell.
And my question is to bring up the thought that, well, let's just say worst case scenario, we don't get the road demonstration project. Is that time to then push maybe a little faster on the Souls Act or?
Yeah. So as we start to digest the federal budget, any impacts to rural demonstration, the potential for souls, those are where we start having the conversation as what our next status is. So as some of those things clarity starts coming from those budget processes, that's when those conversations need to take place, in my point of view.
But Souls is just outpatient. It doesn't have anything to do with inpatient. It's solely an outpatient program.
Yeah, well, the two of them make cost like reimbursement, like equipment.
Right. So what we'd really be looking at is critical access. That's what we have.
Which is that's what I meant to say.
That's what he said.
It's still rolling.
We're still reviewing it. Our census has been higher, so we have got past that 25 days more this year than we have in the past, just because our census has been so high. So that'd be something we have to continue to review. Or we maybe have to ship more patients than we would in prior years. So that's a consideration. From the state level, they've kind of closed out their process. Some of the big ones we have from this year is there was a prior authorization for reform. So the association got together with some of the insurance companies. So they're going to try to fast track some of these prior auths. We're constantly, getting authorization, always winning the appeal. So they're going to start reducing the number of prior auths we need. It's probably going to help clinics as much as the hospital, but it should be a win across the board for all the providers. That was probably the biggest one. CMS did release their IPPS rule for FY26, just came out. There are several changes to quality measures. So health equity is getting taken off for FY26. Yeah, DEI is kind of on the way. Social determinants of health screening is no longer going to be tracked. COVID vaccination, coverage for healthcare personnel. They're adding some future quality measures on well-being and nutrition. So you see the changes from the administration start to impact some of that. From a staffing standpoint, we did conduct a couple of CFO interviews a couple of weeks ago. We had one very good candidate that we're working. So we hope to have more announcement here in the coming week as we start getting through some of the processes. But we are hopeful that we should have a CFO by July at least. I don't want to disclose the name because they haven't gone through a background check, and I don't want to have that in the public record. Something bad happen.
You have one person.
We're working with one person, yeah. Max, I pulled Max into I haven't gone through several CFO interviews myself in the past. It's always been the finance chair has been involved, so I invited Max to come ask all the hard questions.
Something. If assuming that she's a very good candidate, somebody that wants to, her husband wants to be here, they're here looking at homes. Really will be a good team member. I think. I hope the rest of the staff is that way.
I think overall the feedback was good, so we're hopeful. I guess I'd open it up for any other questions that are out there. Any rumors I can address?
The rounding, I'm glad to see that you're really staying on top of the rounding. You're over the 80%, is it 100%?
Well, some of the people we have to continue to encourage. So I don't think it's that we're not hitting the 100%. I think we're not tracking. And so as we look at some of the metrics, I was like, I know the person's out there rounding because I see them out in the hospital. They're just not taking the time to make sure we're tracking ourselves. We'll get better.
When we went through the negotiation this last year for the, with the union, I think one of the undercurrents of that was there was this kind of lack of trust that in a carryover from prior. That's the way you hear that for the next.
You got there so that you can ask questions.
Yeah.
And having gone through hospital week, which was just 2 weeks ago, and we had we were out there talking to staff rounding during that time. I think I saw a higher level of engagement this year compared to prior years. We gave out t-shirts, people are out buying sweaters, you see them in the hospital gear now walking around. So I think we've changed some of that. Or at least
It's pretty good.
Yeah, yeah. So I think as we get to the engagement survey this fall, we should see market improvement. That's my hope.
Yeah. Your point about time and attendance, I had a question for Chad around, you have the new kind of paradigm around how you're tracking, clocking in, clocking out. How's that going?
Are you referring specifically to going from the rounding to the minute by minute?
Yes.
Yeah, so it was definitely a paradigm shift for a lot of folks. But I think we've done a really good job communicating. But, the part about this that works so well is, you come in, you clock in, you get paid for the time, the moment that we actually expect everyone to come in, clock in still 5 minutes early, whatever it is. They're just being paid for that time now. Did cause a few problems on the payroll side, made it a little bit tougher. But we've worked through, I think, the bulk of the issues, and it seems to be going pretty well. Not a lot of concerns at this point.
So people are actually getting paid under the new HR system too, HR payroll?
No, the payroll is part of the phase 1 implementation of the Pro module. So they're still being paid through Meditech.
Oh, they are.
Yeah, and so that we're in the process of, we have about 2 or 3 documents left to give to UKG for them to go ahead and start the payroll side of the build. Once they're starting the payroll side of the build to transition payroll from Meditech to UKG, then we get to do what I call the fun stuff, which is the applicant tracking, the employee self-service, the analytics, all the stuff that's in gold on that list. It's all part of phase 2. That's part of all that self-service, really integrated capital management stuff.
Gotcha. Okay. And what's the timing on that, Chad?
So phase 1 is is targeted towards mid-September. And then phase 2 will be early next year.
Gotcha. All right. Thank you.
Those are go live dates, correct?
Those are targets.
Great.
Other questions for the administrator? Thank you. Liaison, Mr. Sanger.
Yeah, thank you. Joe already covered kind of the main topic of Bartlett interests that we discussed recently, and I'll definitely bring the board's concerns back to my colleagues on the assembly. Thinking in the same way. Otherwise, we are almost done with our budget process. We passed the city budget out of the finance committee. So now we'll go to full assembly on, I believe, the 9th. June, I believe it's June 9th is our next full assembly meeting. Could have that off by a week though. We set the mill rate at the last finance committee meeting at 10.24, so a bit of an increase from last year, but down from what the finance director and the city manager recommended. Just looking to kind of keep it a more reasonable change from what it was last year at 10.04, so a slight increase. We funded a number of community grants, probably the most significant of which might be of interest is Juneau Community Foundation, a $250,000 year-over-year increase for some of those social services grants that they send out. Otherwise, that's going to the assembly and we should be acting on it fairly quickly. I think there's a couple more amendments that might come up on that last date. And other topics that we're moving on to from there, our committee of the whole meeting on Monday We have some continued conversation about the flooding situation, and about continue to be an issue on our plates for probably, the next 5-10 years likely. But we are working on, we've installed all of the barriers on the flood lines, and we're working on actually extending the barriers beyond what we initially saw we'd be able to do to protect a little bit more of the property that's downriver, try and prevent some backflow into some of those neighborhoods, like the Meander Way area. We also are having a discussion on the possibility of moving Juneau into a ranked choice voting style election system. Ongoing topics that's been brought up at the assembly level that we're working through. And then also we've introduced a concept to move to seasonal sales tax, which would come along with a elimination of tax on food or non-prepared food, so similar like food stamp type food, as well as utilities. So really the concept there being shift some of the tax burden from year-round residents to summer visitors by capturing a higher tax rate. So we've been having that conversation kind of casually in meetings. We've just introduced like more specifics to that plan at the last finance meeting. So having law draft up an ordinance to have further discussion on it and try to get that kind of idea socialized out into the public to hear back, pros, cons, and how the community. But really just trying to look for ways to answer some of the questions that people have of, what does the city see as benefit from summer visitors that we see coming in every year? And so those are kind of our big topics that we're working on right now, and sure more will pop up, but happy to answer any questions.
A little off topic, but I gotta ask it anyway. I didn't see in the article, and maybe you guys have considered that, but when you get a construction permit, which of course is a summertime activity, that comes along with not paying sales tax on the items that you purchase, and they're intended to be revenue neutral. So the construction permits in total are supposed to basically offset the loss of the sales tax that you're not getting. Are you guys looking at increase the construction permit fee as part of this?
It wouldn't, as we've discussed, it wouldn't change the construction fee. In fact, that is something that's come up in conversation, just the fact that the permit gives you that tax exemption, because there was a lot of concern in our initial discussions of summer construction season, that if you have a sales tax, that's going to hurt that industry. But so we haven't talked about raising those fees at all. I think it could be not in the spirit of the discussion we're having, I guess. In my opinion.
Have you guys looked at Ketchikan, what they're doing right now?
I know that they have a seasonal sales tax, but beyond that.
So it's a 6 months from October to April, it's 5.5%. And then from April to October, it is 8%.
And ours, same time period. But we're looking at it as 3.5 in the winter and then 7.5 in the summer. So
I don't know if Ketchikan is still taxing groceries. I think they still are.
Yeah, I think they do.
Yeah, I think
they just do. SICA does the same thing. You just don't. They also have the same seasonal, different rates, but same time period. But they tax groceries.
They do tax groceries too. That's what I thought.
Yeah. Yeah, and then taking the tax off of groceries, I see the logic there is it's kind of the most noticeable impact to kind of the average family to see that benefit of the increased tax in the summer.
So right away, see a 5% reduction in groceries.
Yeah, exactly. And utilities as well.
And utilities as well.
Any other questions or comments for our liaison? Next is President's report. And really, as Mr. Steiner said, that what I've been working on for the last month is pretty much what Joe and Kim and others have been working on the sobering center and a couple of other issues that the board has received a couple of emails. It has been forwarded a couple. So those are the things that we've spent a fair amount of time in this last month working on. And hopefully some of those things are going to come to resolution in the not too distant future. And that's it for my report, since the bulk of the discussion was on the time that I've spent last month. It has been working on the sobering center and a couple of issues in a couple of others as well. So I think up next is our board calendar.
We need to get back, we need to get the governance committee back on the calendar. We have a couple of things we need to do. We need to revisit the policy manual, revisit our board education topic, revisit the board self-evaluation, and revisit the CEO evaluation. So I'd like us to get that on the June calendar. Good.
Okay. Are you proposing a date or?
Well, I'm pretty flexible. I wonder what other members of the committee, what constraints they have.
I'd recommend sometime in the week of the 16th.
Who else is on? I should know this.
That's good.
I'm on that one.
I would put on.
Oh, the 19th is a holiday. It's a state holiday.
Juneteenth.
Already said Chris.
Holiday too, right? The package.
Like I was looking at that, it's like, I looked at this today, there's something about that week.
You suggested the week of the 16th?
Yeah,
Except for the 19th,
except for tonight.
which should be fine for me. I'm not on the committee, but I generally attend, so.
Lisa, do you have any?
So I'm available that week, whatever day you choose.
We pick the 17th.
Time.
We have it at noon, we can have it at 1. What would be? Anybody else prefer for me?
Lisa, you're the one that tends to have more restrictions on your time.
My PRN nurse is in town that week, so I'm good for me. Next week, following week.
Let's do the 17th at noon then.
All right.
We should escape. Yeah.
Okay, how's it okay with you?
Are you out of town?
I'm out of town.
Oh,
But Chad could sit in for me.
That makes it easy for you. You should be pushing for that date, Bill.
If Joe approved my week off, that is.
As funny as I did this morning.
Thank you, Joe.
Can't snag it back.
okay. Well, then you and I meet separately and we'll figure something out.
Okay.
See, this would be down.
There is at the top. Okay. So we've, planning committee has been rescheduled to. Pardon?
I'm sorry, I was talking to Jeff. He was talking to me, actually. I responded.
You waited until my back was turned. So credentials committee is standing. It will, that doesn't really change. So, and it's not a public meeting. Planning committee has rescheduled itself for the 12th. Nothing has changed on that, Mr. Chair. Okay. And we're still good for the finance committee on the 13th?
Well, in talking with Joe just before the meeting here, we'd like to push it back a weekish kind of time frame. I don't, 19th is a holiday, so it'd probably be the 20th. Is that kind of what you're saying? So, Dr. Tingy and I think Shelley is on here now. Is that Shelley?
It's on here.
Does that work for you guys, the 20th?
Works for me.
The 13th is better for me, but I could probably make. Is it noon? Is that what we're looking at?
Well, we can
The
flex
20th?
that time, Brent. We can, you know, if we need to do it a little bit earlier, a little bit later in the day, we can do that too.
I can make noon work on the 20th. Let's go ahead and do that.
Okay, let's lock in the 20th at noon, and thanks, Anita, if you just send out a update to the calendar.
So the question is, we've done this a number of times. It's really tight
Yes, I know.
to get the information out in the board packet.
I agree. It is very tight. And we'll make it work. We'll turn around the minutes as quick as we can.
Okay.
Like I said.
I'm committing Sharon to it.
I was just gonna say, okay. All right, and our joint conference.
If I may remind Luke that we should talk at med staff on the 10th again and poll the general medical staff. We should poll the discussion about CMO and stipends and things like that. That's sort of been a major joint conference issue that we've got to settle sometime this year. So let's remind each other. Okay.
That's good. But we're still good for that.
Yes.
Like the calendar is resolved. Any board comments or questions before we take a break and go into executive session? Seeing none, let's take a 10-minute break. And when we get back, come back actually no later than 7:15, please. And then we'll go into executive session. We are back in session, correct? I would entertain a motion, how we usually do the.
Somehow during the break, I had the motion all queued up and.
There you go. It's on.
Oh, here we go. Madam Chair, I move that the Board of Directors of Bartlett Regional Hospital recess into executive session to discuss several matters, including those which by law, municipal charter, or ordinance are required to be confidential and involve considerations of records that are not subject to public disclosure, specifically the credentialing report, medical staff, meeting minutes, patient safety dashboard, personal matters, and legal updates. And Madam Chair, I ask that you be given discretion as to which staff shall remain.
Do we have a second?
Okay.
Everyone in the room may stay for the executive session. We are recording. So I would entertain a motion to accept the credentialing report.
Madam Chair, I move that we accept the credentialing report.
And if there's no further discussion, we are adjourned at 3:37. Thank you all.